one of the most competent veterinary pathologists in India. And I know from my student life, I'm the luckiest student of Ranchi Veterinary College in the session 93-99. And from the student life itself, I have saw the competency of our sir, Dr. M.K. Gupta. And we used to visit his human laboratory, which is from, I think, 91 or 92.
90.
Uh, and we used to get samples and we used to study with that samples in his laboratory. Many times I have visited. And I can say today's lecture, you have arranged Dr. Purnima with most competent veterinary clinical pathologist in my own in India. In my own eye, I think that he is the most competent speaker today. And whatever his personal experience of his career is there, probably he will bestowed upon all the participants, and all the participants probably get very much benefited from the lecture of Dr. M.K. Gupta, sir. So I will not take much time, and I hope that our participants will interact to get maximum outcome from this lecture. And with that, I'm stopping my speech. Thank you very much. And thank you, sir, for joining once again.
Thank you, Dr. Thank you.
Thank you so much, sir. Thank you, sir, for joining us. And now I would like to invite Dr. Deepak Kumar, sir, to introduce Dr. M.K. Gupta, sir. Please, sir.
Okay, Dr. Purnima. I heartily welcome to Dr. M.K. Gupta, sir. Sir is also introduced with me. Dr. M.K. Gupta, sir, University Professor and Chairman, Department of Veterinary Pathology, College of Veterinary Science and Animal Husbandry, Birsa Agriculture University, Ranchi, Jharkhand. He graduated in Ranchi Veterinary College in 1983, and he did his MBSc and PhD in veterinary pathology in 1986 and 1985 under the guidance of luminaries of veterinary pathology, Dr. H.V.S. Chauhan sir and G.J. Jha, veterinary, respectively from Ranchi Veterinary College. His area of postgraduate research was Marek's disease, cypermethrin toxicity. Dr. Gupta sir is a recipient of GRF, SRF, and institutional of merit scholarship, where he stood first in all the program. He was selected for ARS in 1988, but performed to his serve his state and joined as an assistant professor of veterinary pathology in the year 1989. During his career of 35 years, he has guided more than the 100 PGA students in the capacity of major advisor and member of advisory committee. His main area of interest had been clinical pathology, which he is practicing for more than the 35 years and has tested more than the 50,000 clinical samples of blood, urine, feces, milk, and tissue samples. He had been pioneer in establishing the popularizing clinical investigation of sick animals in the state of Jharkhand, which has shown massive such in the use of clinical sample for disease diagnosis. Additionally, he has also worked extensively in the field of poultry pathology, oncology, and toxicopathology. He has collaborated in the development of first ever effectively lumpy skin disease vaccine in India, which has used Ranchi strain for vaccine productions. He has published more than the 100 research articles in the national and international journals. He was awarded Best Pathology Worker Award in 2021 by the Indian Association of Veterinary Pathologists. He has the distinctions of being the first diplomat in Indian College of Veterinary Pathologists from the state of Jharkhand. His main mission in life is to take the veterinary diagnostic facility to grassroots level for the benefit of the masses. Thank you, sir. So, Dr.
Thank you,
Purnima.
sir. Thank you so much for introducing sir very well. And we all know that he holds lots and lots of power over science. Now I may invite Dr. M.K. Gupta, sir, to please shower his blessings and to begin with this technical session. Please, sir.
Thank you, Dr. Purnima, for inviting me. I really thank Dr. Chandrahas, Dean, College of Veterinary Science and Animal Husbandry, Kishanganj, for his nice words and kind words. Let me tell all the participants that Dr. Chandrahas had been one of the most brightest student of our college, and he has brought laurel to our college by raising to such heights at such an early age, and that gives us a lot of proud moments for the all members of our college. And so therefore, thank you, Dr. Chandras, for being alumni and taking the name of our college at the national level to such great heights. Thank you so much for introducing me also so nicely. And I also thank Dr. Deepak Kumar for introducing me with his kind words. Definitely, it is an honor for me to interact with all the participants, and it is I'm really thankful to the administration, the Vice Chancellor of BASU. Vice Chancellor sir has given me earlier also a chance to interact with the faculty in Patna, and this is the second time I will be interacting, and that's wonderful. And it's always an honor to interact with our professional colleagues and students. And I was looking forward to this interaction because I must congratulate Dr. Narendra Kumar, Dr. Purnima and his team for uh, selecting this topic of interacting on diagnostic pathology or clinical pathology, because I very strongly feel that this is one field which is very much underutilized in the veterinary science, and that has led to huge economic loss to the profession. And if we are not able to reach the height, it is probably because we are not fully exploiting the diagnostic pathology in veterinary science. Some of the states are doing really well, like Ludhiana and Chennai and all. But it doesn't mean that other states should not, go into the profession with the backup of diagnostic pathology, because we all know that diagnostic pathology is nowadays considered the most primary thing you have to do before starting a treatment or investigation treatment. So overlooking diagnostic pathology definitely is creating a void, and most of the treatment is being done on presumptive basis, and that creates a lot of economic loss and painful experiences for both owner as well as for the professionals. So therefore, I think all the credit goes to the team of Department of Pathology, College of Veterinary Science, Kishangan, for uh, initiating this workshop and inviting all the very good, efficient resource persons from all over the India. So congratulations to you, Dr. Narendra Kumar and Dr. Chandrahas and Vice Chancellors of BASU. So I would like to start with the topic and is it visible to all? And am I audible to all?
Yes, sir, screen is visible, but it is not in a full screen, sir.
Full screen. full screen. How to go to full screen, Dr. Purnima?
Sir, you can try from this home and then insert. Here we have an icon of slideshow.
Where?
The top left, sir.
Home.
Top left, sir. We have home, then insert, then design, animation, slideshow. In the top, sir, top left. Here we have some icons.
It's not there.
Okay, okay. Then from bottom right, you can see the 70%.
Mm-hmm.
Yeah, just
Make it
first
100%.
yeah. You need you need to press this icon, sir. The first icon that is available here.
Yeah, that
Yeah,
I
this
did.
one.
That I did.
Press, sir, press I5. It will be in a screen mode. I5.
Okay.
Sorry?
F5. Sorry, F5. I'm very sorry. Oh, there is F5 button on
A5.
top. You press that one, sir.
A5, no?
F for fish. F.
Okay,
Row
F5.
top,
Okay.
sir. Top row, fifth button. F5. Yes.
That I did.
F5, sir.
हाँ किया ना.
ओके सर, यहाँ पे लेफ्ट में आप जब सबसे ऊपर देखेंगे ना, तो एक जो आइकन्स दिए हुए हैं ना, होम, इंसर्ट, वी कैन सी फ्रॉम हियर एक्चुअली इट इज
But
अवेलेबल.
it's not visible on my screen. It's like here I see mute, stop video, participant chat, new share.
आपके स्क्रीन पे फुल स्क्रीन है?
हाँ.
अच्छा, तो
एक आप लोग आ रहे हैं किनारे में.
हाँ, आप एक बार क्लोज करके एक बार फिर से स्क्रीन शेयर कर लीजिए सर.
ओके, क्लोज करें, पूरा क्लोज कर दो.
जी.
क्लोज नहीं करना सर, स्टॉप शेयरिंग करना.
हाँ, स्टॉप शेयरिंग सर, स्टॉप शेयरिंग.
स्टॉप.
और अगर नहीं हो रहा है तो हम ऐसे भी कर सकते हैं, वी कैन सी क्लियर.
स्टॉप शेयरिंग तो किया मैंने.
जी,
आप फिर से सर शेयर कर लीजिए.
एक
अब
बार
स्क्रीन
फिर
शेयर
से.
करें फिर.
जी.
आप
फिर भी तो आप लोग आ रही.
हाँ, यस, अभी दिख रही है स्क्रीन. एक बार फिर से यहाँ पे प्रेस की जी. पर
फिर तो वही हो गया ना.
हाँ सर, लेकिन हमको ऐसे भी स्क्रीन दिख रही है, ऐसे भी हम शुरू कर
है ना.
सकते
ठीक
हैं.
है.
जी जी, प्लीज स्टार्ट विद.
So I'm extremely sorry for my incompetence in this field. हम लोग पुराने जमाने के हैं, so I often make things complicated. I'm really sorry. So, but if it is visible, even
it is okay, sir. It is okay. It's okay, no problem.
It's
Okay.
clearly visible, sir. Please, you
Fine,
can
thank you.
start.
So, dear participants, very good morning to all of you. And today we are going to discuss traditional and novel approaches of liver function test and result interpretation. From the topic itself, you can see that we had a very vast topic to cover, which will include the traditional way we are actually analyzing the liver function test, what new approaches have been made or has been developed in the scientific fraternity as far as the liver function test is concerned, and how to interpret the results, when to prescribe what kind of test result. All these are very important as a professional when you are examining animal and trying to confirm the diagnosis, whether it is in the field cases or it is in the research field. You have to be very careful about selecting your parameters for assessing the liver function, because there are so many parameters to be covered. We will come to that one by one. So the liver as such is a master gland or organ. We all know it is one of the most beautiful organ God has prepared, and it's a vital organ, and it has got multifaceted functioning. Sorry. So you can say it is an expert in carrying out multiple tasks at one time. Because it is involved in metabolic functions, particularly the carbohydrate, protein, and fat metabolism. It also plays important role or vital role in detoxification, excretion of waste and toxic products. It is very important for digestion of fat, and it has got the synthetic properties also. It plays central role in synthesis of protein and clotting factors. This is only very few of the functions that we have discussed. As such, liver is an extremely important central organ of the body. Not central organ, rather, central organ is of course heart and lungs, but liver is a vital organ, plays pivotal role in our well-being and maintaining our homeostasis. So if it is carrying out so many functions, obviously there are so many windows through which you can explore this organ, or you can assess the functional capability of this organ. Because it is involved in metabolism, it is involved in detoxification, it is involved in excretion of waste products, digestion, synthesis. So if it goes wrong, these parameters goes wrong. So you must have a clear-cut idea what parameters are to be taken up for examination of the liver in what kind of disease processes. If we say liver, it doesn't mean that we are talking about liver only, because both liver and biliary systems are so intricately intertwined, or they are so independent on each other, dependent on each other, that in reality, if we are talking about liver function test, we are including the biliary system also. We are keeping a tab on the assessment of hepatobiliary system instead of only liver. So it's very important that you have a clear-cut understanding of both liver as well as the biliary system. And this is a gross, you can say, main anatomical feature of liver. We can see that there is right lobe or left lobe, and then there is caudate lobe is also there, and the liver is kept in its position by so many ligaments. Then it has got the bile duct, gallbladder. It is supplied with two major blood vessels, that is hepatic artery and portal vein, and it drains its blood out into the inferior vena cava through hepatic veins. You can see that in the inferior vena cava, the blood coming out of the liver gets drained. So as such, it's wonderful, and it's very important to understand in totality the structure of liver and how it functions. And we can see that liver is always under stress, and we know that when we are under stress, we perform better than in normal state. So therefore, liver, though under stress, I'm telling this because it is getting deoxygenated blood more than the oxygenated blood. The percent.
May I interrupt, sir? Slide is not moving, sir.
No, I have not moved the slide.
He's using first
Oh,
slide only.
sorry. Okay, sorry, sir. Sorry.
No issues. So this the liver is getting more of deoxygenated blood than the oxygenated blood. So it is more susceptible to suffer from hypoxic injury also. And since the blood coming from enterohepatic circulation goes into the liver, so all the toxic components which are being absorbed, if it is there in the GI tract, the liver is the first organ which gets exposed to these toxic agents, and they are capable of actually overcoming these toxicities. And therefore it plays a vital role in maintaining the health of animal or human beings. And we all know that we are students of pathology, or even if we are from graduate of veterinary science, we know that the histology of liver is very important to understand. That liver is present in a lobular fashion, lobular pattern, and you can see that in the center of the lobule there is central vein, and in the periphery there is portal triad, which contains the flattened portal vein, then there is hepatic artery, and there is bile duct, and they have got a very good supporting structure of fibrous connective tissue. And from there the hepatic cords, it moves towards the central vein in the broad fashion, and in between the two cords there is sinusoids which are lined by you can say Kupffer cells. So, so the blood coming from portal vein and hepatic artery goes into the central vein, and from there it joins the hepatic vein, and then it goes into the uh, inferior vena cava. So with this basic information about the hepatocytes, we go into the further detail when we talk of it as a organ. Every organ has got cell. Every cell can be examined uh, with the help of compound microscope or with the help of electron microscope, where we say that ultrastructural features are there. So in liver, the ultrastructural feature is that between the sinusoids, where the blood flows, and the hepatocytes, there is space of Deci. The space of Deci is very important because the exchange of gas and nutrients takes place through space of Deci, and it houses stellate cell also. And the stellate cell or ito cells are very important cells, which normally they are actually storing the vitamin A, but in case of adversity, they may get converted into myofibroblast cells and starts releasing fibrous connective tissue, which will cause fibrosis in the space of DC and which will lead to cirrhosis and all. So and we know that the sinusoids are lined by endothelial cells, and they have fenestrated. They are not continuous endothelial cells. There are spaces between it, and then there is Kupffer cells, which are basically the macrophages, which clears the foreign bodies which are coming into the liver through enterohepatic circulation. So sinusoid and hepatocytes, there is a space between the two, which is called disease space, and it houses the all important stellate cells. So with this background, we can go into the scope of liver function test. Now we know that what liver is, what function it performs, and what are its anatomical and ultrastructural features. In short, we have discussed. Now coming to the liver function test, we know that hepatobiliary disease is an important cause of morbidity and mortality. So many diseases affects the liver, and if liver goes wrong, then the health is adversely affected. So it's very important to know that what are those those changes that takes place in the liver, and how to actually assess the liver function, how to actually find out what functioning of the liver is damaged due to the irritant or the causative agent or the deficiencies or the excesses. And liver can be affected at any age group. It can be seen that this disorder can be seen in any sex or breed of animals. So what is important is that when the liver suffers, it doesn't mean that it always suffers immediately with severe consequences. The disease starts at lower level and then it becomes progressive, and then major manifestation of liver disease occurs. So initially there is only mild manifestation of liver dysfunction. And these are like animal will manifest intermittent anorexia or lethargy. So it's not, you cannot pinpoint that in this animal liver is diseased. But when you go for investigation in such patients, you will find that there is increased liver-associated enzymes. And they are the first indicator of the problem. If there is even mild increase in the level of liver enzymes, one should be very careful that something wrong is happening inside the liver, and we have to further explore it. And if we overlook such things, then what is going to happen? Then there will be overt clinical manifestation of liver dysfunction. And these are basically expressed as clinical signs of more advanced liver disorder is expressed as icterus, we call it jaundice, or ascites, accumulation of fluid in the peritoneal cavity, edema, polyuria, polydipsia, hepatic encephalopathy. If liver is not functioning, the ammonia will go into the brain and it will cause nervous disorders. So it's very important that if you are finding clinical signs which are suggestive of liver dysfunction and they are in advanced stage, it doesn't mean that you have to do only 1 or 2 tests. You have to go for a more elaborate testing regimen, choose more elaborate testing regimen so that you can, basically find out what kind of disease is developing in the liver, whether it is due to hepatic injury or it is due to cholestasis. The bile flow is affected. We have to finally classify what kind of liver problem is there. And we have got all types of tests, which will help in finding out uh, the basic anomaly that is taking place, or the basic changes that is taking place in the liver as a result of disease. So basically, we can classify liver dysfunction or liver disorder into 2 types. One is called liver diseases. Now, this is characterized by all those diseases in which there is injury to the hepatocytes. Hepatocytes are damaged either due to hypoxic injury or due to metabolic diseases or due to toxicity or due to inflammation as a result of infectious or non-infectious
Hello,
causes.
excuse me, sir. Sorry to interrupt you. Have you changed your slide, sir, or are you using first slide?
Yeah, I am in the 4th or 5th slide.
Okay, then we cannot say it, yes, sir. We can only see first slide right now.
Mhm.
It is not changing.
So, shall I do at my end?
Mm. In your screen, okay, it is a screen sharing form. It's in
Yeah,
screen sharing mode in your computer, sir.
yeah,
Okay.
I'm sharing.
Sir, you can stop the slide share and start again. और सर फिर उसके बाद आप स्क्रीन शेयरिंग पे ना मत जाकर सीधे ऐसे ही शेयर करते जाइएगा, चेंज करते जाइएगा.
इसको बंद कर दें.
एक बार सर देख लेते हैं.
ओके.
आप स्क्रीन शेयरिंग मत कीजिएगा. Yes. Now it is we can see the 8th slide, sir.
So I am.
Yeah, like this. Keep it like this, sir.
Okay.
It's 7th slide we can see right now. Is
So,
it the same on your screen?
do you want me to start from the beginning?
No. Yeah, sir, it would be better if you can start like that.
Okay. Okay, I'm really sorry. So we talked about the liver as a gland. It has got the ability to multitask. It's a star multitasking organ of our body, and it carries out a lot of functions. It carries out metabolic functions, metabolism of protein, carbohydrate, and fat. It is responsible for detoxification. It is also an excretory organ. It excretes waste and toxic products, and it plays important role in digestion of fat, synthesis of protein, and all kinds of clotting factors. So when an organ is doing so many works, it will create so many windows through which we can actually examine liver. All those products, their increase, their decrease will help us in assessing the functionality of the liver. And when we talk of liver, we are talking about the hepatobiliary system. We do not exclude the bile duct system from liver function test. It's a part of liver function test. So whenever we are actually examining or performing test, we are performing test keeping into consideration both bile system and liver as a organ. So hepatobiliary system we actually explore. And the liver, or as such organ, has got multiple lobes, right lobe, left lobe, or caudate lobe. It is kept in position by different types of ligaments, falciform ligaments or ligament of Leris and all. It is supplied by 2 blood vessels. One is portal vein and the other is hepatic artery. Dual blood supply is there. That is why we say that true infarct does not develop in liver, because the alternate blood supply mechanism is there. and it supplies the blood through the sinusoids, and then it drains into the central vein. From there, it goes into the hepatic vein, and then it comes out through the inferior vena cava. And side by side, there is secretion of bile by the liver also, which flows in different direction. The blood flows in one direction, in the opposite direction, bile flows, and bile is secreted by the liver, and it goes and gets stored in the gallbladder. And then, as per the need, it is used by body for the digestion of the different food. So that was the gross anatomical feature of liver. अभी दिख रहा है?
यस सर अभी चेंज हो रहा है।
दिख रहा है?
अभी आप सर थर्ड स्लाइड में है, राइट?
हाँ, थर्ड स्लाइड। बट ये फिर आगे क्यों नहीं बढ़ रहा है? नेक्स्ट स्लाइड में नहीं जा रहा।
अच्छा सर, फिर एक बार स्टॉप करके आप फिर से एक बार को आपको शेयर करना पड़ेगा।
ऑप्शन अभी ठीक है?
यस सर, अभी ऐसे ही रहने दीजिए सर, और फोर्थ स्लाइड पे आप जाएंगे एक बार।
आगे क्यों नहीं बढ़ रहा है?
आपने अभी सर स्क्रीन शेयरिंग ऑन किया हुआ है?
हाँ,
अच्छा, तो स्क्रीन शेयर मत कीजिए सर, ऐसे ही सिंपली जो ऑन करते हैं हम, जिसमें सारी स्लाइड भी लेफ्ट में दिख रही होती है, वैसे रहने दीजिए।
ये तो दिख रहा है ना।
हाँ, अभी हम थर्ड स्लाइड देख पा रहे हैं।
ये आगे क्यों नहीं बढ़ रहा?
अच्छा
So kindly try by reducing that percentage, no? Zoom percentage, I think it's 100%. Can you please reduce it to 70% like that, sir? Sir. Then after that, try it, sir, one time. If it is changing, or else we have to present it. Yes, sir. Yes, sir. Okay. Thank you, sir. Yes, sir.
Okay. So this is good for everyone, na?
यस सर।
So, after going through the gross anatomical features, then we know that liver histologically consists of uh, lobules which carries the hepatocytes in cord-like fashion, and blood comes from the portal triad. Portal triad consists of portal vein, hepatic artery, and the bile duct. Then portal vein and hepatic artery sends branches through the sinusoids, and it reaches central vein. In the process, there is exchange of nutrients between the blood and the hepatocytes. And then from central vein, it joins hepatic vein, and then it drains out into the inferior vena cava and goes back to the heart. So hepatocytes, they are arranged in cord-like fashion. Then between the two cord of the hepatocytes, there is sinusoids. Sinusoids are lined by Kupffer cells. Kupffer cells are basically the macrophages, which are responsible for removing the foreign bodies from the blood, foreign factors from the blood, and they are lined by endothelial cells. And between the sinusoids and the hepatocytes, there is space of Deci, which plays vital role. It should be patent, only then the interaction between the interchange between the sinusoids and the hepatocyte will take place. If it is fibrosed, then no interchange will take place and the liver will go into the hepatic failure. So it is very important that its patency is maintained. The complication arises when the stellate cells, which lies in the space of Deci, changes its mode from a storage cell, the ito cell, which stores vitamin A, gets converted under adverse condition into a fibroblast, and starts secreting fibrous connective tissue, which will occlude the space of Deci, so the no interchange will take place, and then it will become difficult to maintain the hepatocytes, and there will be hepatic necrosis, and then cirrhosis or fibrosis will develop. So this space of disc is very important. It is an ultrastructural space which lies between the sinusoids and the hepatocytes. So then coming to the scope of liver function test. So we all know that hepatobiliary disease is an important cause of morbidity and mortality in the animals. And it affects all the age, sex, and breed of animals. So it is very widely present. What happens that any disease doesn't become very severe outright. It starts from milder changes and then it becomes more prominent if we are not capable of controlling that process or the progression of the disease. So earlier on, very mild clinical signs are there, like intermittent anorexia or lethargy is there, but there is also release of enzymes from the hepatocytes. So if we can diagnose early that there is rise in the enzymes, we can diagnose the disease affecting the liver at an early stage, so the recovery will be much easier. But if we are unable to control the disease, then the liver disease, it becomes more progressive, and more prominent clinical signs such as icterus or ascites or edema or polyuria, polydipsia, hepatic encephalopathy, all kinds of complications will arise. And at that stage, you need to go for a much bigger investigation involving all the, all the battery of tests which are available, so that you can pinpoint what kind of cellular changes that are taking place in the liver responsible for the liver dysfunction. So if we classify the liver disorder, there are two terms we are using. One is called liver disease, in which there is injury to the hepatocytes and obstruction in the flow of bile. So we say that there is hepatocyte injury or hepatic necrosis, or there is cholestasis, means the bile is not flowing freely from being synthesized into the hepatocytes and then going to the bile duct, and from there it goes to the gallbladder. If that passage is obstructed at any point, liver disorder will increase, will appear. That is one, and these liver diseases can occur due to hypoxic injury or metabolic diseases or toxicosis or inflammation of infectious or non-infectious origin. So many etiological agents are there which can cause damage to the hepatocyte and the biliary system. Where the next classification is liver failure. When the liver is unable to excrete whatever toxic products are there or the waste products are there, if the excretion process is affected, or it is unable to synthesize the substances like albumin or the urea and all, if it is unable to synthesize properly, then we say that the liver is undergoing liver failure or hepatic failure. So there is distinction between liver disease and liver failure. But overall, liver carries a tremendous reserve capacity. It can work efficiently even at 70 to 80% capacity, even if after the loss of 60 to 70% of its functional capacity. The manifestation of liver dysfunction starts appearing only when 70 to 80% of liver has stopped functioning. So we often miss the development of liver dysfunction because we wait for the clinical manifestations or the biochemical parameters to be expressed very overtly. Only then we will start thinking that the liver has become diseased. But the actual fact is that liver was diseased way back, and we overlooked the primary or preliminary clinical signs, and as a result of which more complicated liver dysfunction has arisen. So it's very important that we detect the liver dysfunction as early as possible so that we correct it in due course of time. So talking about the liver function test or the assessment of liver function, it has been classified into three categories, because one is that there will be enzyme estimation to find out hepatocyte injury. There are certain enzymes which are released from the damaged hepatocytes. Then we go for enzyme estimation that detects cholestasis, stagnation of bile. In stagnation of bile also, there are certain sets of enzymes, the level of which will go up. And then there are other liver function tests which are not related to enzymes. They are chemicals which are either being synthesized by the liver or is responsible or liver is responsible for their excretion. So there we have got so many tests which will not enzymes, which will help in finding out whether the liver is functioning properly or not. So these three categories are there. So before going into into that, let us just understand what is enzymology, how enzyme helps in the diagnosis of the disease in liver or in any other organ. So there are two sets of enzymes. One is called leakage enzymes and the other is called induced enzymes. So leakage enzymes are those which are present in the cytosol or they are present in the organelles. And whenever the cell undergoes injury, these enzymes are released into the serum and the level rises. This is called leakage enzyme. And the other is the induced enzyme, which remains attached to the epithelium, and its production is increased rather than being released or leaked. Its production is increased under the circumstances. Those are called as induced enzymes. So there are different sets of leakage enzymes in each organ system. Like in liver, it is alanine transaminase or aspartate transaminase. Whereas in pancreas, it can be amylase or lipase. Similarly, in prostate gland, it could be acid phosphatase. So there are different enzymes which are specific for a particular organ. And if there is rise in that particular enzyme, it clearly indicates, if we try to connect the dot backwards, we will find out that these enzymes are specific for a particular organ. And if the level of enzyme has increased, it definitely means that particular organ is not functioning properly and there is damage to the parenchymal cells of that organ, and that is why there is release of or the leakage of enzymes. So these two categories are there. One is called leakage enzyme and the other is called induced enzyme. So then we come to how we are going to, explore the damage to the liver. It can be explored by finding out whether there is hepatocyte injury or whether there is cholestasis. The bile duct system or hepatocytes are getting injured. So hepatocyte injury is always accompanied with increase in the level of leakage. And there are four important leakage enzymes of liver. One is called alanine transaminase, जिसको हम पहले SGPT कहते थे. Then there is transaminase, earlier SGOT, sorbitol dehydrogenase, and glutamate.
Dr. China, please mute Kanika.
Now the leakage enzymes, the level of which will increase if there is damage to the hepatocytes, particular parenchymal cells of the liver undergoing injury. What points you should remember while going for its investigation? That these enzyme activity are lost with time. So you don't have much time. Jitna jaldi, the earlier you perform it, the better and the more authentic and repeatable results you are going to get. So don't delay the process of enzyme estimation. I know students, they collect blood, leave it for 1 week or 2 weeks, and then they will try to find out the level. They will get defective levels. So if you want to study enzyme, you should do it as early as possible. Otherwise, you will be losing the enzyme activity spontaneously. Whether you put it in the fridge or you put it in the room temperature, it will go much earlier. Then the serum which has to be tested should be immediately separated. Now we have got SST vials, SST tubes, which is the full form of which is serum separation tubes. We all know that these vacutainers are available. They have got a gel which intensify or hastens the process of coagulation, and immediately within 5 minutes you can separate the serum by putting the blood in the SST vial and centrifuging it at high speed. Immediately the gel will separate the clotted blood and the serum within 5 to 7 minutes. So that will preserve the enzyme for longer period of time. So that should be done. And then you should avoid using hemolyzed sample for estimation of enzyme, because in hemolyzed sample, the enzymes present inside the erythrocytes are going to add up into the serum enzyme level, and that will give you a false result. So all these points are very essential when you are going for enzyme estimation. These are the SST vials. You can see the gels are there at the bottom, and when you put blood into it, these black marks are there. Vacutainer, if you will use, then blood will automatically go up to this point. When you centrifuge it, the clotted blood will go beneath the this thing gel, and gel will reach up, and then above gel there will be serum. So this is a very good technique to immediately separate the serum from the clotted blood. Coming to the leakage enzymes, the most important leakage enzyme from liver point of view is alanine transaminase, or ALT, which was earlier called as SGPT. It's a liver specific leakage enzyme. The maximum concentration of ALT in the body is present in the liver. Its significance is highest in dogs and cats. We have so many species. Every species doesn't have the same, expression of the enzyme under disease condition of the liver. So in dogs and cats, whenever the liver gets injured, the alanine transaminase will be expressed in a raised fashion. So any disease that causes hepatocyte injury, now you remember that liver has to be explored either as a to find out whether there is hepatocyte injury or there is cholestasis. So whenever there is membrane damage or hepatocyte gets injured, there is leakage of the enzyme ALT and its level increases in the blood. Hepatocyte injury may be caused by, we all know, hypoxia, hepatic lipidosis, fatty liver syndrome, fatty liver stage 1, stage 2, which is very common in human beings these days. Due to metabolic alterations, then there is bacterial infections, inflammation, exposure to toxic chemicals, drugs like anticonvulsant drugs, or even malignant cancer of liver. In all these cases, if the liver cells are damaged, hepatocytes are damaged, you can expect increase in the level of ALT. And there is very frequent use of glucocorticoid also. And glucocorticoids or the steroids, they may be of endogenous origin like hyperadrenocorticism, or exogenous origin, which we inject in the form of Rexona and all. So that is going to increase the ALT activity because it leads to glycogenosis in the hepatocytes. There is overload of glycogen in the hepatocytes, and that is going to damage the liver cells, and that will lead to release of enzymes into the blood, and you can expect 40-fold increase in the ALT level post glucocorticoid therapy. So while investigating, you have to keep in mind, history is very important, whether the patient was given glucocorticoid or not. This will lead to hyperglycemia. This will lead to glucocorticoid hepatopathy. So this is expected. This is drug related. This should be always there in your mind. The level of ALT post injury to the hepatocyte starts increasing in 12 hours, and it reaches its peak in 24 to 48 hours. You have to remember that whenever there is regenerative changes, the enzyme is secreted and the level of ALT may also go up. So never think that if there is increased level of ALT, it means that the liver is definitely injured. Even during the disease has been cured and the animal is recovering, there is regeneration of the hepatocytes. There also there may be increased level of ALT. That should be kept always in the mind of, in the back of the mind. And you have to clinically correlate. You know that the animal is recovering and still there is increased ALT level. What could be the possible cause? We cannot say that always that because ALT is increased, definitely the liver is injured. Liver is recovering and there is more synthesis of enzyme, which is increasing the level of ALT in the blood. That should be there in the back of the mind. That is why in all the reports, they say that please clinically correlate. Don't just go by the numbers. You have to use your brain to find out whether the changes are suggestive of diseased liver or the changes are suggestive of, the clinical signs are suggestive of healthy liver. and then you analyze why there is increase in the ALT, keeping in mind that it can increase in a hepatocyte which is regenerating. Then you have to also understand that the liver is badly damaged and still the ALT level is low. What could be the reason? The reason is that it is so badly damaged that the hepatocytes are lost. So where is the hepatocyte to leak the enzymes? So there will be no leakage. So the ALT level will remain normal, but the liver is badly damaged. Both way. The liver is healthy and the ALT has increased. Liver is badly damaged, yet the ALT level is low because the hepatocytes are now lost. And that is why the ALT level remains normal. These things you have to use analytically. You have to clinically correlate with the findings only, then you will get the answer. Otherwise, you will say that the test report is wrong. Then you have to remember that ALT is a good enzyme for liver function assessment. In dogs and cat, it is not a good enzyme for liver function test in cattle and horses because its expression is much low. So they do not select ALT, or the ALT is not considered as a good parameter for liver function assessment in cattle and horses, or for that matter, goat also in ruminants. Then we should also remember that muscles also carry ALT in lower level. So if there is muscular injury, myonecrosis or myodegenerative changes, then the ALT level will show enhancement. So if the liver is functioning normally, the animal is eating properly, there is no jaundice, there is no ascites, everything is normal, no anorexia, but ALT level is high and there is muscular necrosis, then you must be able to know that this increases due to release of ALT from the muscle, not from the liver. It's not a liver disorder, it's a myodegenerative changes. And then you have to go for investigation of those enzymes which are related to muscle, like creatine kinase. You go for estimation of creatine kinase. If its level is high and ALT is high, definitely both the enzymes are coming from muscles, not from the liver. So you will rule out that this patient is not suffering from any kind of liver disorder. Whatever changes are there, it is related to myopathy. The next enzyme is aspartate amino acetate and aspartate transaminase, which was earlier called as SGOT, which is also a leakage enzyme. And they are present in high concentration in many places, but most commonly in liver and in the muscle, both skeletal and cardiac muscle. So AST, please remember, is not an liver specific enzyme, because higher concentration of AST is present in the muscle rather than liver. So you should be very careful again that whether this rise in the AST is due to myodegeneration or due to hepatic necrosis. That has to be ruled out. So you have to do additional test of CK, creatine kinase, to rule out involvement of muscles. Only then, if there is increase in the level of AST, it will indicate that the enzyme is being leaked from the liver rather than muscle. We know that the leakage enzyme is present free in the cytosol, so they get leaked easily and their level rises very fast as compared to the induced enzyme. Increased AST activity could be observed in both hepatocyte injury and muscle injury that we have covered. But remember, in cattle and horses, AST, SDH, sorbitol dehydrogenase, and glutamate dehydrogenase, these are better indicator of hepatic injury rather than ALT, because ALT is present in much lower level. And the half-life of AST is 5 hours in dogs, 1 to 2 hours in cattle, and 50 hours in horses. So what do you understand by half-life? That the spontaneous loss of the enzyme will be seen, half the enzyme activity will be lost in 5 hours in dogs, or 1 to 2 hours in cats, and in 50 hours in horses. So in horses, you can take the liberty of keeping the serum for a longer period of time, but in cats, you have to do it very early. Otherwise, there will be spontaneous loss of enzyme activity. So these things should be very clear in your mind. उसका एक ही formula है, you should always try to carry out the enzyme estimation or assays as quickly as possible. Don't wait and take chances for it to get spontaneously decayed. Then we have sorbitol dehydrogenase, which is again a liver-specific leakage enzyme. Its concentration has been seen significantly in the liver of dog, cat, cattle, and horses. Its high level is always suggestive of hepatocyte injury, not cholestasis. In cattle and horses, SDH is more sensitive indicator of hepatocytes than AST. And the enzyme is stable up to 48 hours in refrigerated condition. So isme, please remember that you have got commercial kits for estimation of enzymes. So commercial kits for ALT and AST is freely available, but commercial kit for SDH is not available. Commercial kit for GLDH is not available. You have to standardize the process in your laboratory, which is a cumbersome thing. If you can do it, definitely sorbitol dehydrogenase is a better parameter in horses as compared to ALT and AST. So that decision is with you. Because for the ease of thing, if the things are commercially available, you don't have to standardize anything. But when you are doing it from the very beginning in your laboratory, you may face so many problems of pH and all kinds of alterations and standardization of things. Lot of, error chances are there. So nowadays we are going for all the test kits which are commercially available. So sorbitol dehydrogenase, though a very good parameter, its commercial version is not available. Same is the case with GLDH. The same, all the parameters which we have discussed about SDH, sorbitol dehydrogenase stands good for glutamate dehydrogenase also. So those were the enzymes associated with hepatocytes injury. Is it clear to all? We have got sets of enzymes, the level of which will indicate hepatocytes injury, the injury to the hepatocytes, loss of hepatocytes. And there are certain different sets of enzymes which are associated with cholestasis. Whenever there is obstruction in the bile passage, there is formation of accumulation of bile and inspission of bile, compression of hepatocytes due to over-accumulated bile, then different sets of enzymes will be released. So those are the enzymes, they are the induced enzymes. Cholestasis induce increased production and activities of certain enzymes synthesized by liver, such as alkaline phosphatase and gamma glutamyl transaminase or transferase. So these two enzymes are always related to biliary system of the hepatobiliary system, bile duct system. The earlier four enzymes that we discussed are directly connected with the hepatocyte injury. But these two, the alkaline phosphatase and gamma glutamyl transferase, their level will always be suggestive of damage to the bile duct epithelium. So if you are suspecting any kind of change in the biliary system, you should opt for ALP and GGT rather than AST, ALT, SDH, and GLDH. Apart from these enzymes in cholestasis, the different variants of bilirubin will also show alteration. And so we have to keep tab on that also. So coming to alkaline phosphatase, again, it's a very important enzyme which is present in the renal epithelium. It is present in the prostate gland. Osteoblast activity leads to release of alkaline phosphatase as well as present in the liver also. So it's a good parameter or a good enzyme for liver function test, but it has got so many ifs and buts. So if the ALP is increased, you have to rule out whether the patient is of young age, because in young growing dogs or animals, osteoblastic activity is much higher. So the level of ALP will always remain higher. So don't confuse in a young animal, ALT is high, ALP is high, so you will think that there is liver disorder. Similarly, if there is bone disease or malignancy or drug-induced rise in ALP, all these has to be ruled out. If there is increased ALP, always remember that there is a possibility of damage to the bile duct epithelium. So there is a simultaneous increase with ALP. There will be increase because there is cholestasis. There will be increase in the bile pigment. There will be increase in the bile acids and all. These findings are expected when cholestasis is there. When there is obstruction in the flow of the bile, You have to go for estimation of ALP, you have to go for estimation of GGT, you have to go for estimation of bile pigment and bile acids. Now, another thing is important, that which test to prefer if you are suspecting cholestasis. So always remember that the expression of ALP alteration or presence of bile pigment in the urine is much earlier than the rise in the serum bilirubin level. So if you will wait for serum bilirubin to be manifested to finalize that yes, there is cholestasis, an earlier version of diagnosis is also there. If you are suspecting that there is cholestasis, please go for estimation of ALP and bile pigment estimation in the urine. You will diagnose the disease condition much earlier as compared to the estimation of serum bilirubin. That is the main expression of this particular paragraph. Now we have to find out what are the common cause of cholestasis and raised induced enzymes. Cholestasis means obstruction, stagnation of the bile in the biliary system. And induced enzyme, we have already discussed that these are the enzymes which are associated with the membrane of the bile duct epithelium, and their synthesis is increased under the influence of pressure or by certain drugs. So hepatocyte swelling due to lipidosis or inflammatory conditions, there is increase in the size of hepatocytes. Inflammation of the hepatic parenchyma may be of infectious or non-infectious origin. The swelling is going to compress the bile canaliculi, and that will lead to more production of these enzymes, ALP and GGT. Their production is also increased under the influence of corticosteroid. Corticosteroid induces increased production of ALP and GGT. So that is called corticosteroid-induced ALP, liver-induced ALP. If it is in liver, if it is corticosteroid-induced, then it will be CIALP. If we use more of anticonvulsant drugs like phenobarbital, phenytoin, primidone, etc., they also induced increased ALP production. So you must always keep in mind, history is very important. We take history, कौन सा drug आपने पहले लिया, and we know that there is history of seizure and all in the dogs, and it is on the anticonvulsant drug, then you expect higher level of the ALP. It is not related to liver. Apart from these two enzymes, we can go for estimation of serum bilirubin or urine bilirubin concentration to find out the status of cholestasis. In cat, it is different. In cat, the production of ALP is much lower. And that is why they say that even mild increase in the level of ALP has got significance. It indicates towards cholestasis in cats in particular. So don't wait for higher level of ALP to be found in cats to assess that there is a problem with the bile duct system. In cat, you expect that minor or mild increase in the ALP is good enough to diagnose that the cat is suffering from cholestasis. So these species variations you have to keep in mind while dealing with a liver disorder. So this I try to explain that this is the system, hepatobiliary system. You can see this is central vein, and we have portal vein, we have hepatic artery. They send out branches in the form of sinusoids, and they fuse together to form one sinusoid. And then there are Kupffer cells, and the blood goes into the central vein. This is the direction. Whereas bile canaliculi starts from liver and it moves towards the bile duct. Two hepatocytes join together to form a channel, continuous channel, and the bile generated in the hepatocytes are secreted into the bile duct and reaches the bile canaliculi, reaches bile duct, and then common hepatic duct, and then it goes into the gallbladder. So the direction of blood and bile is opposite in liver. So here you can see that the two hepatocytes join together to form a channel, which is called bile canaliculi, through which the bile flows towards the direction of bile duct. Then the next enzyme is gamma glutamyl transferase, or GGT. Again, a very important enzyme, which is an induced enzyme, the production of which increases if there is cholestasis. So now we know that for hepatic injury, we have 4 sets of enzymes, of which 2 are commercially available, ALT and AST. And for cholestasis, we have 2 sets of enzymes, the ALP and the GGT. Both of them are commercially available, and you can go for the investigation if it is in the back of your mind that the animal is suffering from cholestasis or there is involvement or obstruction in the bile flow. GGT is again produced in other body organs also, like in pancreas and in the kidney, but the serum GGT activity is only because of the liver dysfunction. The dysfunction of pancreas or kidney does not raise the serum level of GGT, because these organ, when the enzyme is secreted or the induced to be produced in greater amount, they do not go back into the blood, rather they are excreted from the body. The kidney, it will be excreted through the urine. So if you want to find out renal dysfunction, हेलो
Hello.
हाँ, बीच में डिस्कनेक्ट हो गया था.
Yes, sir. I don't know what happened.
Now it is connected, na?
Yes, yes, yes. It's 20th side, we can see.
Okay. So GGT is again very important to find out problem in the biliary system. These 2 enzymes, ALP and GGT, their production gets increased. They are not leakage enzymes. And as far as the reference is concerned in dogs, GGT is more sensitive parameters than ALP. So here I have written in the very first sentence that both GGT and ALP are performed for detection of hepatobiliary disorders. Both glucocorticoid and anticonvulsant agents increase GGT level, though less than ALP. So even in glucocorticoid therapy, all the enzyme level goes up, whether it is ALT or AST or GGT or ALP. The rise in induced enzyme activity is significantly higher in cholestasis than in drug-induced. So drug-induced, we can always find out whether the drug has been administered to the animal or not. Otherwise, it is cholestasis. So by taking a proper history, you can always find out whether the increase in the enzyme activity is because of cholestasis or it is drug-induced. The chances is that it is always cholestasis if no such drug has been administered, which leads to increase in the activity of the induced enzyme. In cattle and horses, serum GGT estimation is significantly better than ALP in case of cholestasis. So this line shows that if you have to select between GGT and ALP, then you should select GGT in case of cattle and horses rather than ALP. But my advice is that we should not be selective. We should go for proper investigation of all the parameters. Always people say that if we will write this, पता नहीं owner इतना पैसा देगा कि नहीं देगा, खर्चा करना चाहेगा कि नहीं चाहेगा. That is none of our concern. As a professional, it is ethical to go for all the tests which are required so that we come to a proper diagnosis rather than trying to save money of the patient, which is going to hamper the diagnosis and the process of disease treatment. So you should not. You can request the pathologist to reduce the cost if the patient is poor, but don't compromise with the selection of tests, because that is going to help you in confirmation of the disease process. So the bottom line about enzyme study in liver disease is very clear. In liver disease, both leakage and induced in the enzyme tend to show increased activity, though the magnitude may vary. Because I told you earlier that early diagnosis will help you to give differential features. If it is hepatocyte necrosis, there will be increase in the leakage enzyme. If it is cholestasis, there will be increase in the induced enzyme. But later on, because they are both intertwined, both hepatocytes and the biliary system, hepatobiliary system, so it all gets mixed up in advanced cases. So it is very important that you go for early enzyme estimations to find out what kind of problem actually is cropping up in the body of the animal. Yes, we have already discussed that in hepatic injury, leakage enzymes show higher values. In cholestasis, the induced enzyme goes up. In advanced hepatic disorder, this distinction gets blurred. So to avoid this, early investigation in the disease process will provide more clarity regarding nature of liver disorder to the veterinarian, whether it is hepatitis or loss of hepatocytes, or it is a case of cholestasis. That was the enzymology, or the enzymes involved in detection of liver dysfunction. Now we have other tests also which will help you in assessing the liver function. And the approach is two-pronged. First is to test the level of substances that are metabolized and removed by liver, like bilirubin, bile acids, cholesterol, ammonia, etc. That is one way of doing it. And the second is the estimation of substances that are normally produced by the kidney, or they are synthesized in the liver. Sorry, not kidney. They are synthesized in the liver, like albumin, globulin, urea, cholesterol, coagulation factors. The hepatocytes are synthesizing it. Bilirubin is also they are synthesizing, but they are getting excreted. So we can go for bile pigment estimation, cholesterol and ammonia estimation, or we can also go for estimation of substances which are synthesized by liver. So bilirubin is the byproduct of erythrocyte or hemoglobin breakdown by macrophages, and it is metabolized in the liver, we all know. And hyperbilirubinemia due to cholestasis leads to jaundice and icterus. So liver function test includes differential diagnosis of jaundice also. It's very important aspect of liver function. So we must have a very clear understanding to what jaundice is, how it is being classified, what tests are to be performed when. That becomes very important. And we all know that jaundice are of three types. One is prehepatic jaundice, where there is excessive breakdown of RBC, which is also called as hemolytic jaundice. The second is hepatic jaundice, where there is actually hepatic necrosis, hepatocyte necrosis, and damage to the hepatocytes, inflammation of the hepatocytes due to toxic components, that is called as toxic jaundice. And then if there is obstruction in the biliary system, we call it obstructive jaundice or post-hepatic jaundice. So in all these cases, bilirubin estimation is the main diagnostic tool with us. And we perform this to classify the jaundice. Actually, what we are treating, whether it is prehepatic, whether it is hemolytic changes, or the liver is damaged, or the biliary system is affected, that will help. So I will not go into the detail of it. Macrophages actually break down the RBCs and produces biliverdin. Then in the blood, it gets conjugated with the albumin to reach liver. In the liver, it binds with protein. And then there is glucuronic acid is there. The enzyme is there, transferase enzymes, which converts into bilirubin diglucuronide. which is water soluble and also called as conjugated bilirubin. And from there, it is liberated and it goes into the intestine, and it is acted upon by bacteria to get it converted into stercobilin, which gives color to the stool, or urobilinogen, which colors to the urine and stool. So, and there is recycling of these enzymes, and it goes back into the liver for recycling. So, and the rest of the enzymes, bile gets stored in the gallbladder. So basically, this is the route through which the broken RBC are reutilized, or its components are excreted in the form of bile pigment. And thus, more simpler, you can say, pictorial presentation of bilirubin metabolism is that the senescent or the old erythrocytes are broken down by macrophages, and then there is production of biliverdin. It is unconjugated bilirubin, and then in liver there is conjugation takes place, and from liver it goes into the intestine. These conjugated bilirubin are water soluble, and the unconjugated bilirubin is water insoluble. So the conjugated bilirubin as well as is acted upon by the bacteria, and then there is production of urobilinogen and stercobilin. Stercobilin stains the feces, urobilinogen stains the feces as well as the urine, and majority of it gets reutilized or recycled in the liver. So any defect, whether there is overproduction of over breakdown of RBC, and the liver is unable to deal with the excessive production of unconjugated bilirubin, that is hemolytic jaundice. Then second is that the liver hepatocytes are damaged, so they are unable to process the even normal level of unconjugated bilirubin coming to it. And the third is that the bile system is not free flowing, so whatever conjugated, unconjugated bilirubin are there in the liver is not being passed into the intestine. So there is regurgitation of these these enzyme, pigments in the blood, which will lead to obstructive jaundice and all. So very clear understanding of these manifestations are important, so that you can find out that patient is either suffering from hemolytic jaundice or toxic jaundice or obstructive jaundice. And to find that out, we have got Vandenberg reaction. Vandenberg reaction is there in the textbooks, but in commercial situation, you find diazo reagents is there. They are using the same, they are working on the same principle of Vandenberg reaction, which uses diazo reagent, which is made up of sodium nitrite and sulfonilic acid. It combines with bilirubin to produce azobilirubin. So if it combines directly, means there is conjugated bilirubin or water soluble bilirubin, it reacts directly with diazo reagent, and immediately pink color develops of azobilirubin. Within minutes, the color change will be there in the mixture chemical. Whereas if there is increase in the hemobilirubin or non-conjugated bilirubin, it requires addition of methanol or alcohol to the diazo reagent for the development of the color, and it is time consuming. It will take around 30 minutes for the color to develop. That is why it is called as indirect Vandenberg reaction. So whenever we are testing bilirubin, we are actually finding out the total bilirubin. It takes 30 minutes time, you find out total bilirubin, then you go for the direct bilirubin test or the direct Vandenberg reaction, and you deduct direct bilirubin from the total bilirubin to find out the indirect bilirubin. So that is how you will find out whether there is increase in the conjugated bilirubin in case of toxic hepatitis, whether there is increase in the indirect bilirubin, non-conjugated bilirubin in case of prehepatic or hemolytic jaundice, or there is increase in both, which we see mostly in case of toxic hepatitis. When we talk of bilirubin, it is very important to understand that fasting hyperbilirubinemia also takes place, which is called as retention hyperbilirubinemia. And this is most commonly seen in cases of horses and cattle. When the cattle and horses becomes anorectic for say 4 or 5 days, then their color of the serum will increase and they will show higher level of bilirubin. This happens because of the presence of increased level of and there is formation of unconjugated bilirubin. Conjugation takes place in the liver. So what happens that in starvation, there is mobilization of fat from the fat depots and this fat reaches the liver. And in the liver, it binds with the ligandin. The same ligandin which is used by unconjugated bilirubin for being to be acted upon by the enzyme system to develop conjugated bilirubin. So because there is competitive inhibition, the fatty acids, they consume the ligandin. Ligandin is not available to the unconjugated bilirubin to get converted into conjugated bilirubin. So there is regurgitation and rise of the unconjugated bilirubin in case of fasting state. And a rise of 5 times the normal limit is seen in horses and the rise of 3 times is seen in cattle. So always remember that in a fasting animal, particularly cattle and horses, you may expect higher level of non-conjugated bilirubin. So that is nothing pathological about it. You have to cure or find out why this anorexia has developed, whether it is ketosis or there is some other problem, you have to find out. When we talk of cholestasis or the obstruction in the passage of the flow, cholestasis could result from disruption of bile flow to blockage in the extrahepatic or intrahepatic channels. Any blockage inside the liver or outside the liver is going to block the flow of the bile, and that will result into jaundice. And these stagnated bile are going to get dried up, which is called inspisation. So inspisation of bile will take place if the cholestasis is persistent, and that is damaging to the liver because the bile is very much irritant to the hepatocytes. Cholestasis, how it develops, whether there is formation of a stone inside the bile duct system or there is space occupying lesion outside the liver or the biliary system. The hepatocytes are getting swollen up, or there is tumor formation, or there is cyst formation or abscess formation. All these space occupying lesion may compress the biliary system to interfere with the flow of the bile. Similarly, hepatic injury like hepatic lipidosis or inflammation also can lead to obstructive lesion because as they grow, as they inflame, they are going to compress the bile canaliculi, and that will result into a stagnation of the bile flow. Similarly, if there is some obstructive lesion in the upper small intestine where the ampulla of water opens, where the bile, common bile duct empties into the small intestine, and if there is obstruction, obviously there will be obstruction in the flow of the bile, and then that will lead to cholestasis. So in obstructive jaundice, elevation of ALP and GGT level is faster and therefore more sensitive test than bilirubin estimation. I have already told you that early diagnosis is very important. So in the first place, you should go for estimation of enzymes because the expression of bile pigment enhancement comes later. The raise of the enzyme system comes earlier. So always go for enzyme estimation in the first place. Then there is hyperbilirubinuria. The bile pigment goes into the urine through the kidney. So because of the passage, they are water soluble, so they come out in the urine also. So the level of bile pigment in the urine is always suggestive of jaundice, and its level increases much earlier in the urine as compared to the blood. So again, examination of urine is more important for early diagnosis of jaundice rather than the examination of blood. Then there is one delta bilirubin, which is very interesting. Delta bilirubin is a variant in which the bile pigment is very strongly attached to the albumin, which is called biliprotein. वो उसको छोड़ने को तैयार नहीं है. So the excretion of these strongly attached bilirubin to the serum protein helps in its sustenance inside the body. So the raised level of bile pigment will be seen for 2 weeks or 3 weeks, even after the cure of the jaundice. That is because of delta bilirubin. It has got no clinical significance because that patient will give normal urine bile pigment. The color of the urine will be normal. Still, the assessment of bile pigment will show raised bile pigment. That is because of delta bilirubin. So always remember that in cured patient also, bile pigment level may remain raised for 2 to 3 weeks. That is because of the presence of delta bilirubin rather than the other kinds of bilirubin. So it has got no much clinical significance. If clinical correlation says that though there is increased bile pigment level, the animal is behaving normally, it is feeding normally, its urine is of normal color, then you should not be bothered that this raised bile pigment is because of delta bilirubin and it has got no clinical significance. Manifestation of bile pigment in different species of animals. Dogs have lower renal threshold for bilirubin, which is much lower in male than in female. Hence, they may show high colored urine very frequently. We all know that dogs में आपको high color का urine आसानी से दिखता है, करने की capacity उनमें कम रहती है. Then, of course, fasting and retention hyperbilirubinemia we have just discussed. It is more commonly seen and more strongly seen in horses and cattle. Diseases which damages their erythrocytes, and there is hemolytic changes. Phosphorus deficiency also leads to hemolytic changes. So hyperbilirubinemia of prehepatic nature is more common in cattle. Then, of course, there is bile acid. Now, bile acid is a substance which is synthesized from in the liver from cholesterol. And these are cholic acid and chenodeoxycholic acid. These are primary bile acids. And they combine with amino acid taurine to form water-soluble deoxycholic acid and lithocholic acid. The bile acid plays vital role in the digestion of fat. Their increased level is suggestive of hepatobiliary disorder. And their level also rises in photo goes up. This we will discuss later what is photosystemic shunt. It decreased hepatocyte uptake in hepatitis. The liver is unable to process bile acid, so its level will go up. Hepatic necrosis, glucocorticoid hepatopathy. In all these conditions, bile acid level will be raised. Or there is decreased excretion and regurgitation of bile acid in the blood in case of cholestasis. So whether it is hepatocyte injury or it is cholestasis, in both the cases, bile acid level may go up, and it may be easy to estimate. You need HPLC or thin layer chromatography or this gas chromatography, mass spectrometry. So all these advanced diagnostic techniques standardized so far, and it's not available commercially. So difficult to actually estimate bile acid in laboratory. Then there is another very important parameter which is ammonia converted into urea for excretion. So ammonia level will go up if there is hepatocyte injury because it will not be taken up and it will not be converted to urea. So whenever there is hepatocyte injury or liver dysfunction, urea level goes down because the hepatocytes are unable to synthesize urea. And obviously, if the hepatocytes are unable to uptake ammonia, the level of ammonia will rise in blood. So ammonia estimation again becomes a very important parameter for finding out liver dysfunction, which is done spectrophotometrically. But the only thing is that ammonia can be measured in laboratory, but it decays very fast spontaneously. Within 60 minutes, you have to perform the test. Ammonia is present in erythrocytes also, and if there is greater contact or longer contact of plasma with blood, then the RBC ammonia will go into the blood and the level will be increased. So separation of plasma is very important. Within 30 minutes, you have to separate the plasma. You have to maintain it in the ice state so that in cold, the conversion is less. And you have to transport it to the laboratory within 60 minutes, and the test has to be performed as quickly as possible. And that is why you see the whole national laboratories like Lal Path Lab or these things, ammonia estimation from other states. Wherever their central laboratory is there, in that city only, ammonia could be estimated. They will not take because there will be spontaneous loss and you will not get the true value. So ammonia estimation is again important, and which is not very much easy to perform, and it cannot be done in any other laboratory where the facilities are not there. But it is an important parameter. Then we have dye excretion test, dye excretion test, DSP dye excretion test, or in green regular interval at what time complete excretion of these dyes. If the liver is not functioning properly, they will be retained in the blood for a longer period of time, and their values will be seen for a longer period of time. But the only thing is that these dyes, when they are injected into the body, may induce an anaphylactic reaction. So because of the health hazard it carries, it has been discontinued and it is no more in use. One should go for estimation of bile pigment and bile acids for uh, liver function test rather than these dye excretion tests. Then of course those parameters can be actually examined which deals with synthesizing capacity of liver. Like liver synthesizes albumin. So if there is hepatitis and there is loss of hepatocytes, the level of albumin will go down. Not in the early stages, but in the later stages. Similarly, in cirrhosis also, where most of the hepatocytes are lost or replaced by fibrous connective tissue, the serum albumin level goes down. But same is not true for total protein. Albumin is synthesized in the liver. Total protein may come from dietary source also, and its level may not be decreased in cirrhosis or in hepatitis. So albumin is one parameter which is regularly being done as a liver function test. Then globulin is also there. Same way, globulin level will also go down. But when there is liver damage, there is damage to the will go into the circulation in the body, and the body will react against these immunologically, and there will be more production of immunoglobulin seen in liver disease because the liver could not uh, neutralize those proteins coming to the liver. As a result, it's a reaction of the body in the form of immunoglobulins in other organ system will result into hyperglobulinemia. So globulin level may show decrease or it may show increase also in liver disease. Similarly, glucose is important parameters, and the hepatocyte dysfunction may lead to hyperglycemia or hypoglycemia. We all know that glucose is converted into glycogen and stored in the liver hepatocytes, and whenever required, there will be glycogenolysis and glycogen will be converted into glucose. So if the liver is not functioning properly, the glucose will not be utilized and there will be hyperglycemia. Or if glycogenolysis is not taking place because of the liver injury, there will be hypoglycemia. So both of the manifestation can be there in liver disorder. Liver dysfunction may lead to hyperglycemia when the uptake of glucose is affected, or there may be hypoglycemia because the glycogenolysis is not taking place. Similarly, urea, liver synthesizes urea, and hepatic failure. Always think urea is the role, and that is why it damage. There is increased creatinine level and low urea level. That low urea level is because the liver is not able to produce the urea. So therefore, they say that the true kidney function test is creatinine rather than urea, because creatinine is not affected by
Sir, it is disconnected again.
Yeah, I know. Actually, we have a bad weather in Ranchi.
Yeah. Yes, sir. This is a
That is why. Now it is visible, na?
Audible, sir.
yes, sir. Yes.
Yes,
Okay.
audible, sir.
So always remember that liver plays important role in urea metabolism, and it may give a misleading picture to veterinarians. Then, of course, cholesterol is there. Liver is the major site of cholesterol synthesis, and bile is a major route of cholesterol excretion. So, hypocholesterolemia will develop due to hepatic injury because it is not able to convert or excrete the cholesterol through the bile. Or hypercholesterolemia will develop in cholestasis. If the liver cells are injured, there will be hypercholesterolemia. If the excretion of the cholesterol is interfered because of cholestasis, there will be hypercholesterolemia. So both of these, hypocholesterolemia and hypercholesterolemia, develops in different sets of conditions. That should be always kept in mind, that hypocholesterolemia is seen in hepatic injury, hypercholesterolemia is seen in cholestasis. Then, of course, coagulation factors are synthesized by liver, and one of them is prothrombin, and estimation of prothrombin time, which is very important. There will be clotting disorders. The clotting time will be delayed in liver disorder. So, to confirm liver dysfunction, physicians always say that go for prothrombin time estimation. Increased prothrombin time is always indicative of liver dysfunction. So that is why the coagulation factor or prothrombin time constitute a very important liver function test. So liver diseases are there. There are so many liver diseases and their corresponding laboratory findings. Let us have a very brief discussion on what are the possible liver diseases and what biochemical changes or diagnostic changes you expect in those conditions. So first is portosystemic shunt. Portosystemic shunt is a condition in which the portal vein gets directly connected with the hepatic vein, and the blood bypasses liver and goes directly into the hepatic vein and then into the inferior vena cava. So that is associated with microcytic anemia. Patient suffers from microcytic anemia because the iron gets sequestered in tissue in the macrophages. It is not available for the blood or synthesis of hemoglobin. So the patient suffers from microcytic anemia. And of course, there will be increased bile acid level, increased ammonia level, enzyme level is not affected. Increased bile acid because the hepatocytes are being bypassed. They are not coming in contact with the hepatocytes. So there is no utilization of bile acid. Ammonia is also not utilized for the synthesis of urea. So their level goes increased. Again, the lipid metabolism alteration will affect the integrity of the erythrocytes. So anemia will be the result. Microcytic anemia will be because the cell membranes are damaged. So these are the manifestation of portosystemic shunt. That is, animal suffers from microcytic anemia. There is increased bile acid in the blood. increased ammonia in the blood, but the enzyme level is not affected because the hepatocytes are not there. Photosystemic shunt develops mostly in cirrhosis. So when cirrhosis is there, a new uh, passage is created by connecting portal vein with the hepatic vein, and blood bypasses liver parenchyma and goes directly into it. So that is why uh, this thing uh, enzyme level is not affected. Then of course, if there is hepatic necrosis or hypoxia, the leakage enzyme will increase. ALT, AST, SDH, GLDH level will increase. They secrete albumin, urea, glucose, cholesterol, coagulation factors. Their level will go down, and induced enzymes may increase, but not more than 3 times its normal limit in hepatic necrosis. Here you can see the portosystemic shunt. There is hepatic artery and portal vein, and then the blood drains into the hepatic vein and into the inferior vena cava. Here you can see that the portal vein bypasses liver, doesn't go into the liver, but it connects with the hepatic vein and passes out of the liver. That way, the substances which the portal blood is carrying for uh, metabolization by the liver will remain in the blood, and their level will go up in portosystemic shunt. So there will be increased ammonia, there will be increased bile acid. But because the hepatocytes are not contributing anything, so the leakage enzymes and the induced enzyme level remains more or less normal in portosystemic shunt. Similarly, in case of cirrhosis, the blood doesn't flow into the liver, which has undergone fibrosis and loss of hepatocytes, and they are diverted towards the gastric blood vessels and the esophageal blood vessels, and lot of varicosities. You can see, the participants can see that there are formation of dilatations in the blood vessels, and they may rupture, and there may be internal bleeding in the stomach or in the esophagus. These are called esophageal or gastric varices. And all those patients which are suffering from cirrhosis, they go regular checkup for after 3 months. Endoscopy is being done to find out whether these blood vessels or the varices are intact or they are bleeding, and then through laser they are being closed. So that is a part of cirrhosis, the manifestation of cirrhosis. And here you can see hepatic necrosis is there. The hepatocyte, the liver has become so much mottled. These white areas are the areas of necrosis. Here you can see that these are the zone of normal hepatocytes, and these are the necrosed hepatocytes. So when there is necrosis, all the enzymes, leakage enzyme will be drained into the central vein, and from there it will go into the hepatic vein, then it will go into the inferior vena cava, and then the blood level of these enzymes will rise. Liver also develops focal lesions like abscess, infarcts, neoplasm, etc. And in those cases, you may expect both the things. If there is more of hepatic injury, there will be more of leakage enzymes. If there is more of cholestasis, there will be more of induced enzymes. So in localized lesion also, the nature of increase may vary depending on the type of changes that is taking place in the liver. Hepatocytes are being damaged, leakage enzyme will increase. Bile flow is being obstructed, there will be increase in the induced enzymes. This hepatic lipidosis is a very common complication in human being these days, fatty liver we say. In cat also it is very significant, and here there is excessive accumulation of fatty acid in the hepatocytes, and that compresses damages the hepatocytes. There will be increase in the leakage enzyme, or pressure of swollen hepatocytes due to lipid accumulation will pressurize the bile channel, and there will be more secretion of induced enzyme like ALP and GGT. So chances of increase in both leakage enzyme and induced enzyme is very common in hepatic lipidosis. The liver may also, the patient may also show increased glucose level and increased prothrombin time. There is damage to the hepatocytes. Here we can see the changes, gross changes we see in hepatic lipidosis. The liver has become pale in color because of excessive fat. This is normal fat. This is excessive fat accumulation, severe lipidosis. So fat is there, which is going to damage the hepatocytes, and there will be leakage of enzymes. And the pressure of fat-laden hepatocytes on the bile duct will lead to more synthesis of induced enzymes. In hepatic lipidosis, the hepatocyte, this is normal hepatocytes. You can see the cytoplasm, healthy cytoplasm. Here the cytoplasm is very much distended, very much enlarged, and they are filled up with fat. So they are definitely going to pressurize the bile canaliculi, and there will be release of more induced enzyme. And it will interfere with the flow of bile also. That will result into this thing, jaundice. Here is special staining for Sudan 3, Sudan 4. Special staining for fat is there. You can see the fat globules in the hepatocytes. Here also fat globules are present, which has enlarged the hepatocyte. Then of course, steroid or corticosteroid hepatopathy. This happens because of the whenever we inject or we use corticosteroid, there is hyperglycemia, and hepatocyte shows excessive accumulation of glycogen, and that injures the hepatocyte. So there is swelling of the hepatocytes, which will compress the bile canaliculi, and there will be more induced enzyme like alkaline phosphatase and gamma glutamyl transaminase. Then of course, biliary abnormalities are there: cholangitis, cholangiohepatitis, and extrahepatic bile obstruction. Whenever there is biliary abnormalities, there will be increased leakage enzymes due to increased irritability. Bile is very irritant, so it is going to damage the hepatocytes, and there will be release of leakage enzymes into the circulation. And of course, more bile will pressurize the bile duct epithelium to induce more synthesis of ALP and GGT. So in biliary abnormalities, there may be both increase in the leakage enzyme as well as induced enzyme. And you may get jaundice also. Here you can see biliary abnormalities, lot of bile accumulating in the liver parenchyma, and depending on the concentration, maybe pale green, green, or dark green color. Bile duct obstruction leads to cholestasis, which may be in common hepatic duct, common hepatic duct, or common bile duct, or ampulla of Vater. All wherever it happens, the bile above that particular obstruction will result into bile duct, bile pigment accumulation and all. We talked about retention of bile and inspisation or drying up of the bile, and that leads to formation of inspissated mass of bile. And here you can see these yellowish discoloration. These are all bile. They are overloaded with bile pigment. So such kind of picture will be seen histopathologically if there is retention of bile in cholestasis. If the patient is suffering from cirrhosis, it's a chronic liver disorder, progressive damage to the hepatocytes, and the hepatocytes are lost and they are replaced by fibrous connective tissue. So when the hepatocytes are lost, then the chemicals which are will go down. There will be reduced urea and globulin level and all. Initially, when the hepatocytes are being damaged, there may be increase in the leakage enzymes, but later on, the level of leakage enzyme also goes down. So often, a dog suffering from severe hepatitis may not manifest any biochemical changes. That is because the hepatocytes of that particular liver is not there to secrete the enzymes into the blood. So therefore, despite of suffering from very severe liver disorder, the enzyme level may show normal levels. So all these clinical correlation and the pros and cons and the possibilities has to be kept in mind while treating the liver disorder. Then of course, end stage liver disease, where the functional capability of the liver has been lost up to 60 to 80%. There will be mild increase in the enzyme and moderate increase in the induced enzyme. That will happen only if the hepatocytes are surviving and they are injured. If they are lost, these rise in the enzymes will not be seen. And of course, reduced level of glucose, urea, and albumin in end stage liver disease. Then you can go for urine examination also. I have already told you that urine is considered a much better parameter because the changes are much earlier in urine than in the blood. So urine, you can go for estimation of bile pigment, bile salt, and urobilinogen. Bile pigment will increase in toxic hepatitis. We have got Meline test, we have got nitric acid, Fauchett's test, foam test. They have got strips, but my personal experience is that we should go for biochemical tests. These are very simple tests and give you very good result. Strips, they have the tendency to become less effective with the passage of time because of the oxidation and all. So it's always better to go for manual biochemical testing. And Meline tests are very, very simple, and you can do that. You can estimate urobilinogen, the level of which increases whenever there is hemolytic jaundice, or the this thing in case of obstructive jaundice, both bilirubin and urobilinogen may be present. Bile acids can also be detected with the help of sulfur test. So Meline test, you take barium chloride, mix it with urine, filter it, and add Fauchett's reagent to it. If there is development of green color, then it is positive for bile pigment, which is very simple. I always not like these strip tests. So Meline test helps you in finding out bile pigment. Urobilinogen is detected by Ehrlich's test. We have got commercially available Ehrlich's reagent. We mix Ehrlich reagent with the urine, and if there is development of cherry red color, it is positive for urobilinogen. Urobilinogen is seen mostly in the urine in case of excessive non-conjugated, excessive breakdown of RBC. The liver is unable to process the excessive hemobilirubin being sent. So urobilinogen is produced in excess and it comes out in urine. Bile salt and bile acids, sulfur test we do. In the urine, we simply put few granules of sulfur. If it settles down, then it is positive for bile salts and bile acids. So very simple tests are available, which will dysfunction or not in case of urine examination. The sulfur test, the sulfur will settle down. If you pour sulfur, bile salt, if it is not present, it will not settle down. If it is present, then the sulfur granules settle down. Similarly, Ehrlich's reagent, you mix urine with Ehrlich's reagent, there will be cherry red color developing in the urine. That is positive for urobilinogen. So when we talk of interpretation of liver function test, these are, we have already discussed, but let us repeat it, that in acute liver disease without cholestasis, the level of leakage enzymes ALT, AST are significantly elevated. But induced enzymes are raised only 3 times the upper level. Both the enzymes will increase, but in cholestasis, the induced enzyme will be much more. In acute liver disease, total protein albumin remains normal because the hepatocytes are there to synthesize it. Prothrombin time is best for assessment of liver dysfunction. In chronic liver disease, the albumin levels are low, but total protein level may be elevated. Whenever there is hepatic metastasis or bone metastasis, the level of ALP and GGT with normal bilirubin will be seen. I will skip all these because we have already discussed. Let us skip it. Young animals with only raised ALP is suggestive of osteoblastic activity. This we have already discussed. Isolated ALP in adults is suggestive of Paget's disease. Means only ALP has raised. It means that the bone formation is slow, bone degradation is higher, and that is why the ALP level has gone down. Alkaline phosphatase level has gone up. If the ALP level is very high, it is suggestive of biliary cirrhosis. If the GGT level is very high, then alcohol intake is more. If the ALT-ST level is more than 25 times the normal limit, it is suggestive of acute viral hepatitis and toxic hepatitis. And if it goes beyond 50 times the normal limit, then ischemic hepatitis is the probable cause. So the level of enzyme activation or enzyme enhancement has also got significance in the interpretation of the disease condition. Now, this is important that what are the serological markers for diagnosis of hepatic fibrosis? Hepatic fibrosis, we know that it leads to cirrhosis and loss of liver. So in early, if you want to diagnose it early, whether the patient is going into the fibrosis, hepatic fibrosis, and ultimately into the cirrhosis, you should go for estimation of serum hyaluronic acid, which is produced by activated stellate cell. I have already discussed that it plays a vital role in fibrosis. And activation of hepatic stellate cell is brought about through hyaluron, is the primary driver of liver fibrosis. So if there is increased serum hyaluronic acid level, it is suggestive of fibrosis. Similarly, laminin, which is the main glycoprotein of the basement membrane, its level, if it is raised, is suggestive of fibrogenosis. Similarly, serum procollagen 3 and terminal peptide, its level also goes up in cirrhosis. And the serum collagen type 4, which is the most important structural collagen of the basement membrane, its level also raises in hepatic fibrosis. So if you are suspecting chronic liver disease with fibrosis, one should go for estimation of serum hyaluronic acid, laminin, serum procollagen 3 and terminal peptide, and serum collagen type 4. These tests are not available commercially. You have to go for standardization of the test in your laboratory to find out changes. These are the alcoholic liver. You can see hobnail liver, micronodular type, macronodular type in viral hepatitis and all. The hepatocytes are lost. There are fatty changes in the alcoholic liver. And then Mason's trichrome stain has been done to find out that excessive fibrosis has taken place and there is loss of hepatocytes, fatty changes. So obviously when there is loss of hepatocytes, the liver function goes down. Then hepatocellular carcinoma is also a very important condition in which the liver cancer develops. And there are certain markers for diagnosis of hepatocellular carcinoma. They are classified into 4 types. One is called oncofetal antigens and glycoprotein antigens, in which serum alpha fetoprotein is the most widely used tumor marker. Human beings में भी होता है that alpha fetoprotein अगर positive है, then we think of hepatocellular carcinoma. Now, please remember that a variant of alpha fetoprotein is alpha fetoprotein L3, and the other is the des gamma carboxyprothrombin DCP. Now, these two antigens, they are secreted by active hepatocytes in malignancy. In hepatocellular carcinoma only, these two agents will be secreted. Alpha fetoprotein can be present in normal condition also. Non-malignant hepatopathy may lead to alpha fetoprotein. But in hepatocellular carcinoma, these two are the differentiating antigens. Presence of alpha fetoprotein L3 and DCP is clearly the differential features between the malignant and the non-malignant hepatocellular carcinoma. Then we have certain enzymes, like the level of these enzymes are higher in hepatocellular carcinoma. The glypican 3, GGT2, alpha 1 fucosidase, TGF beta, tumor specific growth factor supplement, AFP, they are all, their level goes up in hepatocellular carcinoma. Then, of course, there is more expression of alpha fetoprotein mRNA genes and GGT mRNA in hepatocellular carcinoma. So the estimation of genes, detection of these genes will help in finding out that there is progressive hepatocellular carcinoma present in the body. Then, of course, in hepatocellular carcinoma, there is more synthesis of cytokines like vascular endothelial growth factor, IL-8, interleukin 8. They are the useful prognostic indicators. So we have certain set of markers which will help in diagnosis of hepatocellular carcinoma, which is one of the most common type of liver cancer being evidenced both in human being as well as in animals, particularly in pigs. You can see this is the invasive type of hepatocellular carcinoma affecting the whole liver. And here you can see the pleomorphism, the size of the nucleus is variable, anisocytosis and isokaryosis. There are mitotic activities. Here also the same thing. There is pleomorphism, which is hallmark of anaplastic changes. So coming to the final part, that what are the other techniques apart from the biochemical parameters or the tumor markers or the markers of fibrosis? We have imaging techniques which are playing vital role in the diagnosis of liver diseases. And these are, we are using ultrasonography, those centers which have, though I have no shame in saying that we are very poor in diagnostics, in imaging diagnostic imaging techniques. Almost non-existent in our country, only few centers probably. So ultrasonography can be used. We have CT scan, which will help in finding out the exact nature of liver, whether it is increased in size, decreased in size, it's whether there is mottling or not. Further clarification can be we can get from MRI, where the magnetic resonance imaging is there. Then this is very important one called endoscopic retrograde cholangiopancreatography. Means you put a endoscope through the stomach into the intestine duodenum, and from there you send a probe through the ampulla of Vater into the common bile duct or into the pancreas to find out the gross features of these passages. So that is very important, whether there is obstruction or cancerous changes taking place in the liver or in the pancreas, in the bile duct or in the pancreas, which is called as ERCP. Then we have percutaneous transhepatic cholangiography. Instead of injecting into the vein, the liver is explored from the skin, and the probe is directly taken into the bile duct, and the contrast media is put into the bile duct, and then it is being imaged. So that is called percutaneous transhepatic cholangiography. I will show you the pictures. Then we have operative cholangiography. You create a laparoscopic holes and put the contrast media into the bile system. Then we have operative cholangiography. Then of course PET CT, that positron emission tomography or radionuclide scanning. This is one of the most latest finding in which radioactive material is injected, and they have the affinity for the tumor cells, fast multiplying cells, so they can actually single out even one cell if it is present, which is of cancerous nature. There it will show images of those cells can be seen with the help of PET scan. These are all being done. ऐसा नहीं है कि नहीं होता है. In foreign countries, they are doing it. They are implementing it. In our places, I'm not very sure that There are certain, centers which are doing CT scan, but more advanced, I have doubt. Then forget about all these uh, high-end, you can say invasive or non-invasive imaging techniques. You have got simple digital X-ray. If you have got, you can see the liver. You can find out whether it is increased in size, where there is variation in the density of the hepatic parenchyma or not. So all these imaging techniques plays vital role in finding out the liver diseases. Here you can see the ultrasound is being performed and the CT. Now we have got MRI, we have got PT scan also, PET scan also, PET CT. Here MRI picture is there. You can see that the density change. You can see as if you are looking at a gross organ with so much of tumor lesions, malignant lesions in the parenchyma of the liver. This side is the stomach. So the liver, entire liver is, invaded by the tumor cells. And this is PET scan, PET scan, where the radionucleotide material is injected and it goes and gets localized in the tumorous sites, malignant sites, and which can be imaged very clearly that even a single cell, if it shows radionucleotide activity, it is suggestive of, you can find out that there are some metastatic changes also taking place, or the dye is coming in the urine also. So this helps in, this is the advanced stage, but even in the early stages, or the tumor has been excised or surgery has been done, whether there is residual cancer cell present in the body or not, that can be actually examined with the help of PET CT. Then, of course, I talked about endoscopic retrograde cholangiopancreatography, in which the probe is put through the stomach. It goes into the duodenal loop, and from there, a probe is sent into the common bile duct or into the pancreatic duct to find out the features and to find out the pathological changes taking place in the bile. So this is a very important, this involves surgeons. Endoscopic retrograde cholangiopancreatography, ERCP. Then, of course, percutaneous transhepatic cholangiography. Here, the injection is made through the skin, and the probe is put into the bile duct, and the dye is injected. And if there is block, you can see the equidense substances or the stone inside it. So this can be diagnosed by imaging technique also. This is called percutaneous transhepatic cholangiography. These are yet to be explored by us. Of course, in plain radiograph, you can see the liver size is normal. Here you can see it has become very much increased. So a rough idea of enlargement of the liver can be seen through normal X-ray radiograph also. So with that, I would rather say that the onus is on us to explore the science and show the path for enhancing diagnostic capabilities, which is need of the hour. Whether you go for biochemical tests, serological tests, you go for molecular diagnostic, you go for imaging diagnostic, let us work together to improve this part of our science, the diagnostic capability. If we will not improve, we are definitely not going to excel in our field. So with these words, I would thank all of you for your patient hearing and all the glitches that I developed during the presentation because of my ignorance in handling such presentation. So thank you so much. If any question, I can answer.
Thank you so much, sir, for delivering such an informative and interesting topic. Clinical pathology is something I personally find very much fascinating. So participants are requested, if they have any question, please ask. So we have one question in the chat box. Hello, am I audible, sir?
Yeah,
Yes,
yeah.
one question.
So we have one question. Is that, sir, what are the histopathological alterations we can get in gallbladder in obstructive jaundice?
you don't get much histopathological alterations in obstructive jaundice. You remove the obstruction and things will be all right, because excessive bile, if present, you are going to get accumulation or the inspissated bile present in the liver rather than in the gallbladder, because capacity, and gallbladder is equipped to hold the bile, but the liver is not equipped to hold excessive bile. These bile are very irritating hepatocytes also. So there will be presence of overloading of bile in the cholangioles, excessive, that I have shown the picture in the two changes you will find. You will find inspissated bile. You will find uh, cholangioles showing excessive accumulation of bile, and there will be degenerative changes in the hepatocytes as a result of excessive bile in the liver. And of course, the patient will suffer from jaundice and all. In the gallbladder, you don't find major change.
Okay. Sir, I also have a query.
Please.
So you have said that alpha fetoprotein is a good marker for the tumor injury.
Yeah.
But this is something we also, this is a particular enzyme is also released by the other organs also. So
Yes.
how will differentiate whether it is from the...
That I have already told you, Dr. Purnima, that there are two variants, alpha fetoprotein 3 and the DCP. They are secreted only by hepatocellular carcinoma, not by, any other tissue. So their presence has to be detected. If you want to differentiate whether the growth is hepatocellular carcinoma or it's a normal hypertrophic growth.
Okay,
So,
okay. We
the
should go for
estimation
the
of those,
specific...
more further, specific tests will help you differentiate between the non-malignant and the malignant cases.
Okay. So we have one more question. How do we differentiate ascites of hepatic origin and cardiac origin?
Cardiac origin, you don't get ascites as such. Cardiac origin may you get hydropericardium and all. Ascites may, if you go for ultrasound, you will find that cirrhosis is the main cause of ascites, in which there is portal hypertension, and the and hypoalbuminemia is also there, that leads to loss of albumin into the peritoneal cavity. And of course, there will be reduction in the size of liver because it has undergone fibrosis. So when you will do this thing ultrasonography, the size of the liver will be reduced. And of course, if you go for serum albumin estimation, other enzyme estimation, you will find that the total albumin level is gone down. If the liver is functioning normally and the heart is gone wrong, the albumin level will be normal. But if the liver is not functioning, it has undergone cirrhosis, the total albumin level will be low. That is the main differential feature.
Okay, sir. Any other queries, participants? Okay. So idea is, sir, you can stop screen sharing, please.
Okay.
It is stopping. Thank you so much, sir. Since we don't have any further questions, I would like to invite Dr. Nareen, sir, for his closing remarks on today's lecture. Please, sir.
Thank you, Dr. Purnima. I, Dr. Narendra Kumar, express my sincere gratitude to Dr. M.P. Gupta sir lecture, traditional and novel approaches of liver function test and result interpretation to our participants, including our faculty also. Sir, we know that you are renowned veterinary pathologist and clinician. We are eagerly waiting for your lecture since inception of the training program. Your in-depth knowledge in the subject of liver function test and way of discussion on the subject in the lecture left profound impression to our faculty and participants, and the clarity with which you shared your knowledge was commendable. The practical application and research-based acumen or insights that you have presented will undoubtedly stimulate fresh perspectives within our faculty team. I am sure that the information you have shared will assist us in writing the project on liver-related problems in our area and ongoing teaching and future opportunities. Once again, thank you for carving out the time from your busy schedule to support our initiative. Your contribution to our educational endeavor is profoundly appreciated. I wish all the best in your ongoing work and look forward to potential future collaboration in near future. Thank you, sir. Thank you.
Thank you very much, Dr. Narendra, for
Yes,
nice
thank you.
words.
Thank you, sir. Thank you. It
Thank
was
you
a very
so much,
nice lecture,
Dr.
sir.
Narendra.
And I have heard full lecture, sir, and it was just like a storytelling. I have recapitulated all my knowledges.
Thank you so much.
And
It was
it was
really
so
wonderful
nice,
to
sir.
interact
Thank you
with
very
all
much.
of you.
Sir,
Thank you
personally,
so
sir,
much.
you have enlightened my knowledge very well, sir.
Please visit sometime, sir. When we call you, sir, please visit our college, sir.
Okay,
Yes.
sure. I will come. Definitely. It will
Okay, sir.
it will be an honor.
Thank you, sir.
Definitely.
Okay,
Thank
thank
you,
you,
sir.
sir.
Thank you so
Thank
much,
you.
sir. The
So much.
lecture
Thank you,
was
Dr. Purnima. Yeah, thank you so much.
thank you. The lecture was very awesome, and I hope you will join us again in person as well, sir.
Sure. Definitely.
Thank you so much, everybody, for joining us on Sunday. And shall I end this meeting with the permission of Dean, sir?
Yeah, please.
Okay.
Thank you.
See you, everyone, at 3 o'clock for the another session.